Right, let's make a start, everybody. So, this is being recorded. So, yeah, thanks for coming tonight. It's a bit dark and cold outside. I think this is the final lecture of the 5th year of this public lecture series. So, yeah, tonight I'll talk a little bit about sort of the role of drugs in surgery in what I say the war against obesity. The premise being that typically all else does seem to fail quite a lot, and when I say all else, I really mean diet and exercise. For the vast majority of people, tend to be not that effective at helping them to manage their weight over a long period of time. Why am I giving this lecture tonight? So my background, should introduce yourself, James King there. My background is very much, I did a PhD looking at appetite regulation and the interaction with exercise. That was several years ago now, and during the time when we were studying appetite and some of these appetite hormones that we were looking at, some of the drug companies were starting to be interested in some of these hormones as well, and have since manipulated these naturally occurring molecules to develop drugs, which has sort of entered the drug pipeline now. And I guess alongside that as well, at the same time, bariatric surgery or weight loss surgery was also becoming more popular, and is very popular today indeed for the treatment or for the management at least of morbid obesity or severe obesity. So I'm just really going to give very much an overview of what is the status quo in terms of what is out there to help people manage obesity. My clicker doesn't seem to want to work tonight. So this is the outline of what we're going to go through. So I've split the talk into sort of 3 parts so that it's hopefully easy to digest for everybody. So first of all, I'll just show you a bit of evidence to back up my claim that all else does fail for the vast majority of people in terms of diet and exercise. I'll then have a quick look at what the pharmaceutical companies have up their sleeves, what's in the pipeline at the minute, what's due to be coming forwards. And then again, we'll have a quick look at weight loss surgery and the different types of surgery. And within all this, we'll look at what these different therapies can achieve in terms of what the science tells us, at least. And I put the little diagram of the whistle-stop tour because you could certainly have a module, if not a master's program on these topics. So it is very much a whistle-stop tour of each of these different bits we're looking at. So to start with, why does weight loss typically always fail? And sort of, I could have picked out a whole host of data that shows us time and time again. People really always struggle to lose weight, or if they do manage to lose weight because they're very motivated or they enter a very structured program, weight regain happens in the vast majority of all instances. And this is just a little bit of data that I've actually blanked out some of the information there because I'll use this slide later on, so I don't want to give the game away. But ultimately, this was a very famous study in Sweden that was looking at weight loss surgery. But I've just left on here what actually happened in the control group. So this was about 2,000 individuals in Sweden who entered the Swedish obesity study, which began in the late 80s. And they followed these individuals for 20 years. But these individuals were the ones who decided that they didn't want to have surgery. They just wanted to enter sort of formal medical management programs for people who are morbidly obese. And ultimately what you can see here is that actually if you go into sort of standard care, which typically is advice to change your diet and to exercise, over very long periods of time when these individuals are followed up with these little bumps in the road, you can see people don't really lose weight. But on top of this actually, when I show you the data later, there was about 2,000 people here, and by the time we get 20 years later, there's about 100, 150 or something like that. And actually the people who've dropped out are probably likely to be those who've actually put weight on. So really, what we're really seeing is probably the weight would have increased if you had measured everybody across that long period of time. So really just evidence to suggest that people do struggle to lose weight with normal programs of diet and exercise. And some more recent data in the UK to sort of back this up. This was data from the UK Clinical Practice Data Link, so over about a 10-year period. There was about 75,000 obese men and nearly 100,000 obese women. And so this was just a cohort of individuals obtained from medical records that we have in the UK. And they looked at probabilities of individuals obtaining normal body weights over time. So if you had a body mass index of 30 to 35, which is the lower end of obesity, or if you had a BMI of 40 to 45, which is more severe, sort of morbid obesity. And the main point to take is that for both men and for women, the probabilities of individuals obtaining a normal body weight within this period of time is very low. So 210 for men in the lower category, one in 124 for women. And if you had a more severe obesity phenotype, the odds are quite astronomical really. So 1 in 1,290 for men and 1 in 667 for women. If you actually look again in the same study at the chance of obtaining 5% weight loss for the same categories, the odds are slightly better because it's easier to lose 5% and get back to a healthy weight. But the important point is that even people who decrease their body weight, when we look at their medical records, the vast majority of individuals have regained that weight a few years later. And sort of in this paper, the conclusion of the authors was very much like we should stop telling people who are morbidly obese that it is actually even possible to lose significant amounts of weight and keep it off with normal sort of diet and exercise programs. And the final bit of data on this, we sort of looked at losing weight, but even in people who can lose weight. So these are studies where very intensive programs have been used, very low calorie diets here, for instance, or this was a very famous diabetes study where there was lots of support to help people to lose weight. And you can see when there is lots of support over a short period of time, people can lose weight, but ultimately this is not really real life. But then after that, again, significant weight loss comes every single time. And if you look at any review papers on this, you'll see statistics around sort of saying that sort of maybe 5% to 10% of individuals, when we look at all of the studies, are able to maintain significant weight loss over a long period of time. So 90 to 95% of people cannot do this. And that sort of begs the question, why? It seems we can, sorry about this. We can put people on the moon, we can clone sheep, we can edit DNA, we can grow organs, but we can't seem in this day and age to be able to help people to obtain a healthy body weight. So really, you just want to have a little bit of a look now to see what's going on. And I should have also said, actually, there's been some suggestions within the literature. I'm just going to pause for a minute because I'm going to take this microphone off. Like a buzzing bee in my ear. Okay, so there's been some suggestions that actually we should think about people who've lost weight. We should talk about people being in remission or having obesity remission. And the analogy that they use is the same as a recovering alcoholic. Once you've been obese, your physiology and metabolism is completely different and you'll never go back to being the same again. So even if we support people very much to lose significant amounts of weight, we need to continue to support these individuals because otherwise the chances are the weight will go back on because of the change in physiology. And that's what I'll look at in the next sort of few slides. And just before I do that, this is probably lecture. I just wanted to sort of outline some of the thoughts for why people tend to fare not very well on diet and exercise programs. So people can chip in with this, but from my experiences, the reason why diets tend to fail is because people see diets as short-term interventions and they become very motivated, maybe for 6 weeks, maybe 2 months, but ultimately they don't see these things as lifestyle changes. So they want to do something for very hard, very intensely for a short period of time, but get fed up and ultimately start to revert back to habits. And if you look at any of the programs like Slimming World or Weight Watchers, from personal experience of knowing people who've gone to these programs, they teach people to change their behaviour and to adopt a new lifestyle rather than an immediate change that's going to show benefits. Also, another one is, from what I see, and even discussing this with students in the lectures, most people don't have a clue how much energy are in food and drinks. Quite miraculous, really. If I look at certain foods, if they're creamy, if they're sweet, you think, yeah, they're going to have lots of calories, but some people just don't have this idea or this feel for what might be bad for you. On top of that, we've got very thrifty genes, which I'll speak more about later, but ultimately we have a physiology that when we try to diet, we get hungry, we crave foods. And when you combine that with all of the nice foods around us in the modern environment, that is something that very much facilitates people wanting to put weight back on. And then finally, one point that I'm very passionate about is people read a lot of media nonsense. So the general public are bombarded with lots of messages in the media and lots of magazines, and I would imagine that more people read these magazines than do journal papers. So that this is the information that people are receiving. And just to give you examples, these are recent articles taken from current newspapers. So, by eating like a squirrel can help you lose 3 stone by Christmas. The military diet lose 10 pounds in a week. Overnight diet will help you shed half a stone in a week. And even a taco diet helped a guy to shed 50 pounds by eating nothing but tacos. So the serious point of that is that this is the information that people in the general public get. And that was just a few snippets. So the scientists, I guess, were sort of facing a bit of a battle to get the right information out there. I think it was Jack I was talking to the other day about some exercise scientists and nutritionists are saying that we need to stand up and be more vocal. And most of you, I'm sure, are aware of Brian Cox, who is the physicist and who's out there on television getting the right science across. There's an argument now that exercise scientists and nutritionists should stand up and be a bit more vocal, particularly with things like Twitter, Facebook now, and we should be better at getting the science out there rather than leaving it to sort of bog standard journalists. The same with exercise as well. Again, if you speak to anybody not within the exercise science sphere, people haven't got a clue about how much energy they burn in physical activity, and obviously most people massively overestimate how much energy they do burn. On top of that, people might start programs and obviously adherence drops, whether it's because they don't like exercise. It can be quite painful and not very enjoyable at times. And again, individuals quite often, I suppose, linked to point 1 there, they will reward themselves for the effort they have done by having, energy-dense foods, cakes, biscuits, those sorts of things. On top of that, quite often people will go to the gym or do a formal bout of exercise and then go and sit down for the rest of the day and almost negate what they've just done within the gym. And there's even a theory now that actually total daily energy expenditure is a regulated variable. So most people think we do more exercise, our total daily energy expenditure just goes up in a linear fashion. There's a suggestion now within the evolutionary biology sphere that actually the more exercise you do, at some point there's a levelling off in your total daily energy expenditure, because you then decrease the amount of energy you spend on other things like growth, maintenance, repair, these sorts of things. And again, with exercise, there's this false belief in the media. So how to lose weight and get fit in 12 minutes with 12 basically stretching exercises. Fitness expert, how to lose over 6 kilos with 30 minutes of exercise in a week. Completely unfeasible. And this is the best, from GQ magazine, 8 scientifically proven ways to lose weight without any exercise or diet. Scientifically proven. I did look today, and the readership of GQ is about 400,000 people buy the magazine every month, and over 16.5 million people look at it online. So this is the how widely these magazines and this information is disseminated. But anyway, back to the sort of the science of it all. Whenever I speak about obesity and weight loss, I always, a couple of master's students here tonight, I always go back to evolutionary biology and survival physiology. And people famous quote, "Nothing in biology makes sense except in the light of evolution." So when we talk about energy balance and weight control, you have to remember that for hundreds of millions of years, finding enough food to stay alive was the most important thing. It was the number one priority when you got up every day. And ultimately people went through periods of very low food availability or famine, and the individuals who were able to survive were those people who were the most efficient in terms of their metabolism. It's only, I hope this works, it's only in the last 150 years that this has come along with our modern environment technology, where we don't have periods of famine. So effectively, you've got a genetic makeup that is helping you to seek out high calorie, energy dense, tasty foods, and to conserve energy as best as possible to survive periods of famine. But ultimately, we don't have periods of famine anymore. We have as much food as we want, which has been processed and designed by scientists to taste as good as it can, so that ultimately we have all of this lovely food and we're putting weight on in our current environment. So Dan Lieberman, who's an evolution biologist at Harvard, he terms obesity as a mismatch disease. In terms of there's a mismatch between our genetic constitution and our current environments. Okay, so we need this perspective in mind when we think about obesity and weight loss. So why do diets fail? Well, we'll first of all look at the appetite side of things, but ultimately this was a study published in the New England Journal of Medicine where it recruited a relatively large sample of obese men and women, and they made them lose, well, they helped them to lose 10-15% of body weight, and then they maintained that lower body weight for a year. And what you can see here, these are all appetite hormones. So ghrelin is a hormone that stimulates appetite or hunger, and all the other hormones here are appetites that suppress hunger. But ultimately what you can see on each diagram is the levels in the blood in response to a meal test at baseline before they lost weight, then immediately after they'd lost the sort of 10 to 15% body weight, and then a year later. And if we look at ghrelin, so this is the baseline level in the black, then afterwards we can see ghrelin levels have increased quite a bit after they've lost weight, and then they're still higher after a year. And then if you look at the other hormones, the complete opposite is apparent. So effectively, when you've lost weight, the body is recognising this, and it's trying to compensate through changes in these hormones that are linked to appetite. So you're hungrier. And I haven't got the data here, but if you look at, in response to the same sort of intervention, if you look at people's food cravings, appetites, interest in food, they all respond similarly. So when you lose weight, you have all of this physiological change that makes you want to seek out more food and put the weight back on. Linked to this as well, if this was a study done down in London, and again they got a group of obese individuals to lose some weight, and before they lost that weight and then afterwards they put them in an MRI scanner to look at their brain. And when they put them in the scanner, they made them look at a host of different food types, and the images you can see here are a pretty complex procedure called functional MRI, where they look at brain activation in different areas. And ultimately, the brain lights up in different areas when they're activated, and they were particularly interested in this study at sort of reward-related areas or hedonic areas related to food intake. And I tend to describe to the students these areas are the voice in the mind that when you've been out for a 3-course meal, you've had your starter, feeling a bit stodged, you've had your second course or your main course, and you're really feeling stodged. So then somebody gives you a menu with dessert on it, or you see the dessert trolley come past and you think, yeah, I'll have pudding, I want pudding. Not because you need it, it's just because you see it and you think, wow, that looks tasty, I'll have it. And that ultimately is these reward areas that are making you want to crave these different things. But ultimately this study showed that when people have lost the weight, these reward areas of the brain are lighting up or activated a lot more than when before. So you lose the weight, and these centres that are responsible for craving and helping you to seek out high-calorie foods are going into overdrive, and again, wanting you or encouraging you to lose weight. And if anybody's ever tried to diet, you know that you're always very much aware of the foods around you. It's almost as though somebody is putting foods in front of your face. It seems to be always around you. So we've looked at the energy intake side of things when we sort of try to diet. This sort of shows what happens to energy expenditure. So there's a program in America, television program called The Biggest Loser, and ultimately they recruit individuals who are sort of massively obese, and there's a prize for whoever can lose the most amount of weight. So these figures here show you people's baseline sort of body weight, what happens after 30 weeks, which is when the program ends. So they've lost a significant amount of weight, sort of 60 kilos. And then they've also followed up in this paper people 6 years later. And these bars indicate people's resting metabolic rate in calories a day. So this is just the amount of energy people expend each day just to be alive, to complete normal metabolism. And what ultimately you can see in the blue and the red, the blue is when they measured people's metabolic rate accurately at each point, and then the red is what is predicted based upon people's actual body weight. So your resting metabolic rate is very much linked to how much to your body mass, but particularly how much lean mass you have. So you can see that at the beginning these are pretty similar, but then when people have lost weight, you can see that the metabolic rate has gone down by about 600 calories, but actually the decrease you see is actually more than what would be predicted based on that new body weight. So this is what the green bar indicates. So it's saying that after 30 weeks in this reduction in body mass, metabolic rate is actually nearly 300 calories lower than we would anticipate based on somebody's body weight. And this process has been termed adaptive thermogenesis. It's basically the body's way to try and conserve energy when you've lost weight to really get you back to where you were before. Well, the novel aspect of this paper was that even at 6 years, when people's weight's gone back on, well, nearly all of it, this adaptive thermogenesis is still persisting. So people's metabolic rate is nearly 500 calories lower than what it should be. Okay. So this very much, if you think about an individual trying to maintain lower body weight, you're competing against your body, which is adapting and trying to get you back to where you were before. A good analogy is like your phone. When your mobile phone is low on battery, it goes into power saving mode. It's exactly the same principle. When you're low on energy availability, it's your body shutting down to be more efficient, to stop you losing further weight. Because in survival terms, it makes no sense to be losing weight. For hundreds of millions of years, we wanted to put as much weight on and to store it as most efficiently as possible. And on top of that, because when people lose weight as well, you're obviously eating less, and because we expend energy burning food, if you're also eating less, then the amount of energy you burn each day eating food decreases. So again, this is just another factor that is contributing to pushing people back towards their high body weight. Another sort of aspect related to energy expenditure is that there's a suggestion as well that when you lose weight, people become more lethargic and actually don't move as more. So this was just a study in America where they got individuals to sort of lose weight over a period, and they used a very accurate technique called doubly labelled water to very precisely examine people's daily energy expenditure and physical activity. And effectively, I won't go through this in depth, but they showed that when people have restricted calories and reduced weight, people's physical activity is going down as well. So it's almost as though there's this central drive coming from the brain, making you lethargic and reducing the amount of energy that you expend. And sort of finally, on top of that, even when you do physical activity, when you're at a lower body weight, the amount of energy you burn decreases. So to keep kind of burning the same amount of energy that you did through physical activity at your first or your maximum body weight, you continually need to do more and more physical activity. And this graph ultimately shows you the energy expenditure in kilojoules. So if you divide that by sort of about 4, you'll get calories. But ultimately, these are individuals who've reduced body weight from baseline. So we started at 105 kilos, went down to 92 at 9 weeks, and then at 22 weeks we were down to 84 kilos. And this just shows you how energy expenditure doing the same paced walking at the different speeds. So I think average walking speed tends to be sort of 3 miles an hour or nearly 5 kilometres per hour. But you can see that from baseline to week 22 with that drop in body weight, that the energy burn from here to here is decreased by 25%. So again, it's just another factor that when you've got to a reduced body weight that will contribute to you certainly stabilising, if not putting the weight back on. And ultimately, all those things that I've just showed you really do contribute to why physical activity tends to be not particularly great for most individuals in society for helping them to lose weight, and also particularly dietary interventions as well. And this has obviously got to the point now, I think everybody here is pretty aware we've got a problem with obesity in all developed nations really. And obviously with that, if we're saying that two-thirds of, certainly in the UK, two-thirds of individuals are obese, two-thirds are overweight, about 25% are obese, there's a huge market there for pharmaceutical companies to develop something that, if effective, will make them lots and lots of money. So really what I'll do now in this part is just to go through briefly the little bit of history around weight loss drugs and tell you a bit about what's currently out there and available for people. And just to contextualise this, this is just a figure I showed my students, but ultimately weight loss medication is designed to fit here, so in the yellow box. It's designed as a strategy to help people lose weight in between those who can sort of use diet and exercise, but not quite those individuals who really qualify for weight loss surgery yet. So if we go from left to right, we've got sort of normal body mass index or normal weight, and then we get progressively more obese. And this is where weight loss surgery tends to be sort of positioned, and the medications are kind of marketed to fit in this gap here, so at the lower end. So the idea is we get people with this weight loss medication, help them lose some weight so we can get back down to an area where diet and exercise might be useful. But with the medications, we sort of have these factors in mind. So they're targeted for individuals with a BMI over 30, so that's an obese BMI, or if your body mass index is overweight at 27 with comorbidities like you have type 2 diabetes, abnormal blood lipids or high blood pressure, these sorts of things. At the minute there's 5 approved in America and 2 in Europe, just because there's different regulatory bodies which oversee these, and all are prescribed in conjunction with physical activity and diet, although in the clinical trials where these drugs are tested nobody ever really monitors that. And it's a trade-off between how the effectiveness of these drugs and the side effects that they will undoubtedly bring. So the risk to benefit ratio is important, and as we'll see, the cost of these is also certainly a barrier at the moment to their widespread use. And just to sort of outline, so when we talk about weight loss drugs, the context, I'm talking about drugs that have been rigorously tested for safety and effectiveness in gold standard clinical trials. I'm not talking about supplements that we go back to the glossy magazines. I'm not talking about supplements that people say, take this berry and it will help me lose 10 kilos overnight. I'm talking about trials that have gone through sort of all these different phases of research. So tested in healthy individuals in small numbers, then tested in patient groups in smaller numbers and using placebos, tested in patients in bigger numbers and comparing to the current industry standard. They're then given a license in America by the Food and Drug Administration or in Europe by the European Medicines Agency, and then the drugs basically can hit the market. And even once the drugs have hit the market, at this point here we do what we call phase 4 studies or post-marketing studies, and this is where when we get loads and loads of people taking the drug, with these large numbers of people, we can then keep an eye on them to see if with these larger numbers, if any safety issues begin to emerge. And particularly with weight loss medications in the last 20 years, it's at this phase where sort of 2 or 3 have been available on the market and then have been withdrawn because people have started to have heart problems or psychiatric problems. And we had quite a long period actually where there were no drugs available for the long-term treatment of overweight and obesity. And very briefly, just to give you a context, so this was just a table that I stole out of one of the books that I have. But going back sort of 100 years now is when people started to think about weight loss drugs. And in the very beginning, we had people who were looking at using extracts of thyroid to increase people's metabolism, which was all very good until people started sort of overheating and effectively dying. The same with dinitrophenol in the 30s. People, this was a drug basically to regulate metabolism and contribute to a higher energy expenditure. But people developed cataracts and had nerve problems and also developed hypothermia. Amphetamines are all very good. They make you alert, they suppress appetite, but they're addictive and cause other problems. And the list sort of goes on, and one of the most promising ones for a while was this fenfluramine and dexfenfluramine, but after quite a while it showed that people started to have heart problems. So again, this drug was withdrawn. So as I said, for quite a long period of time, there were no medications available because the target effect would work, but then the off-target effects were too severe to keep the drugs on the market. And 2 particular drugs which were out there, so the one on the left, sibutramine. This was a drug that basically increases the amount of serotonin and noradrenaline in your brain, which suppressed appetite. Got approved in America and the UK in 1997. But then in 2010 was then withdrawn because it was causing people to have heart attacks, strokes and dying, and that was identified in those phase 4 post-marketing studies. Similarly with rimonabant, this is a drug actually, you may have heard that if people smoke cannabis, people get munchies. This is because that triggers this cannabinoid receptor in the brain, and this drug works by blocking that receptor, which is great because it switches off appetite, but that receptor is also related to mood, stress, arousal. And what they found in the post-marketing studies with rimonabant was that people actually started to get depressed. I think 10% of people were getting depressed and 1% of individuals were starting to have suicidal thoughts. So because of this, because of that off-target effect, the drug was then subsequently withdrawn. So again, that left us with very little. We're now sort of several years on, and there's been a lot of sort of work that's gone into this area from the pharmaceutical companies. And as I said at the start, we've now got 5 agents approved in the USA, 2 in Europe. The European regulation body tends to be slightly more strict. What we tend to see with drugs at the moment, we can achieve about 10% weight loss with the best drugs, and that's always very much the best that's achievable in clinical trials. In actual practice, when we get out into the sort of the real world, that figure tends to go down a little bit. There's a suggestion really until we get drugs that can help people lose weight up to about 15%. Some of the medics are not going to be that keen to prescribe these drugs, so there's some way to go. But as I said, these are expensive. So the most expensive one, drug called Liraglutide, which I mentioned, is $1,000 a month in America at the moment. That obviously has implications for if the drugs are going to become available, obviously within the UK with a National Health Service. All of them have side effects and all of them have contraindications, and we'll look at 1 or 2 of them in a minute. But suffice to say at this point that 4 of those drugs all work by suppressing appetite within the brain through different mechanisms. One drug that's available in the UK called orlistat works by switching off the production of a pancreatic lipase enzyme that helps us break down fat. So basically we cannot digest fat, so we excrete about 30% of the fat that we eat, and that obviously leads to the excretion of calories. And these just sort of outline very top level the different mechanisms. So the blue ones at the top here, these are the ones that are available in Europe at the minute. All of these are available in America, and the red ones are the additional ones in America. So I'll go through in more depth the top 2, so orlistat, liraglutide, and I'll also go through phentermine in more depth, just because these are the ones that are available in Europe. And phentermine topiramate, or Fentop as I'll call it, this is actually the most effective one that is out there at the moment. So it's not available in the UK, but of all of these, it's the most effective. Lorcaserin, again, this is similar to sibutramine, which I mentioned before. This has been developed, though, to target, rather than just to increase serotonin, it actually targets a specific receptor. So it is more directly targeted, so it has less off-target effects. So this produces the appetite suppression, but doesn't cause cardiovascular problems. And then this one at the bottom, naltrexone bupropion, this works, again, similarly, by changing levels of dopamine and noradrenaline in the brain, which contributes to appetite suppression. And they're the ones that I'll go through there in the nice fancy stars. So, orlistat, this is the one that I mentioned just a moment ago. So this has been available for quite a while now, and since 2007 you can actually buy this over the counter in the UK or anywhere. So if you get it on prescription at 120 milligram dose, you take that 3 times per day, but you can actually get this form in any pharmacy, which is basically half the dose, and again you take this 3 times a day. Costs about £35 a month, and this is sort of the mechanism here. So usually when we eat fat, it goes into the intestine. We have these enzymes that come out into the intestine and break the big globules of fat down, and then that gets taken into the blood. But ultimately, relatively simple to sort of understand. This orlistat blocks these enzymes, so ultimately these big fat globules don't get absorbed across the intestine and we excrete them. It doesn't take a genius to sort of work out what some of the side effects might be from this. You'll have a lot of gut disturbance. Loose bowels would be the nice term, or the most appropriate term to sort of mention for the most common side effect. And actually I think aversion therapy tends to be seen as the way that this really works. So people associate eating with the side effects, and that's really how the drug works. And just to show you how effective this particular drug can be, this is a meta-analysis, or just a collection of studies that have all had randomised trials. So somebody's taken the drug, somebody's taken placebo, and ultimately when we sum all of the evidence, this was published in the British Medical Journal, so reputable publication, we see about 3 kilos or 3% body weight loss. So, for somebody who's obese, it's not going to change your life. Potentially could help people start moving and lose a little bit of weight, but it's certainly not going to cure morbid obesity. The second drug available in the UK, so this is a drug called Liraglutide, which we do quite a lot of work on within our biomedical research centre with colleagues in Leicester. This is a drug that's been licensed as of 2015 for weight loss in a high dose, but at a sort of a more moderate dose a few years ago was formerly licensed for the treatment of type 2 diabetes. So if you've got type 2 diabetes, chances are you may well get this drug now. And that is because the main, one of the main mechanisms of action for this drug is that it helps the pancreas make insulin and it suppresses glucagon, and those two mechanisms contribute to improved blood glucose control. So obviously very important for people with diabetes. On top of that, it also suppresses appetite. So this drug is basically a synthetic form of a gut hormone called GLP-1 or glucuronide peptide 1. And effectively, this is secreted after we eat into the blood, travels through the bloodstream, gets to the brain, and binds to receptors which switch off appetite. So the chemists have looked at this naturally occurring hormone and developed a sympathetic counterpart that we can pharmacologically use to our benefit to switch off appetite. And in sort of the trials that have looked at this is just one of the first trials on this where they compared to the orlistat drug. You can see what's achievable with this drug. So this is one of the sort of classic trials where they just randomise individuals. So over 500 to start with were randomised at this point here to different conditions. So we always have a placebo group. So these individuals basically injected water. And it's interesting that even these people who are motivated can lose nearly 4 kilos even when they're injected water. That's important why we sort of have that control group. If we had orlistat, these individuals were losing probably about another 1.5 kilos on top of the placebo. And if you can see, if you were taking liraglutide, this is what we'd say is a dose response. The greater the dose, the greater the weight loss. And this 1.8 dose is what's licensed for diabetes. And that in itself is quite novel because a lot of diabetes medications make people put on weight, which is a problem. But actually this drug not only improves blood glucose control but also helps weight loss. But then you can notice as we increase the dose with the top dose here, we see significant weight loss. So you're looking at, so take 4 off that, you're sort of looking at about 5-6% at best. So certainly better than orlistat. Again, probably not going to change your life. And this is the expensive one that costs $1,000 per month in America. I've just shown this because when the drug companies actually do these trials before they get their license, the number of people who achieve 5% weight loss and 10% weight loss are quite important benchmarks. And again, I won't deliberate over this, but you can see that as the dose of liraglutide goes up, quite a high percentage of individuals can lose 5%, which is where the health benefits really start to occur. And actually quite significant amounts of people can even get to sort of 10%, where lots of health benefits definitely start to occur. And then when you take this into an even bigger trial in obese individuals, so with nearly 4,000 participants, and just compare it to placebo, these are the sorts of figures you get. So consistent again, with about 2%, 2 to 3% body weight loss, maybe with placebo, and up to sort of 9-10% there. So again, we're looking at around 6 or 7% with liraglutide. This isn't, as I said, this isn't available in the UK yet, basically because it's too expensive. So our regulatory body, the National Institute of Health and Care Excellence, don't recommend this to be used yet because it basically costs too much for the benefits that it brings. And just to, based on that, obviously these drug companies they're still pushing, and Novo Nordisk, who make liraglutide, have actually developed a slightly different version called semaglutide, and this is just a slight modification to the drug, and ultimately increases the half-life. So they've got now, rather than a once-a-day subcutaneous injection, they've got a once-a-week drug, which is this semaglutide. And a recent report, this summer, suggesting they're getting in 14% weight loss. So they're getting closer and closer to the kind of the level of weight loss that the medical community would certainly sit up and take note of, and probably to the point where we might actually see some of the drugs emerge on the market. The last one to mention is the one that I said was available in America. This is the Fentop. This was actually, so this is approved in America but rejected by the European Medicines Agency. So they looked at the evidence, the portfolio of studies, and said for the effect that you're getting, the risks are too much. So uncertainty about risks to the heart, psychiatric problems, and also problems with memory, I think, if I remember rightly. But this is a combination drug, which is interesting. So it's two drugs that on their own reduce appetite, but the side effects in high doses are severe. So what they did was they lowered the dose and then put them together, and by slightly targeting different pathways, they get a superior effect. I think this is, from what people say, this is the way a lot of these sorts of medicines will develop in the future. And with this drug, there are variable doses, and it's up to the medical professionals to sort of titrate the right dose for the individuals. So one reason why this drug doesn't tend to be used so much in America is because the dose titration regime is quite complex, and the medics don't like really dealing with it. It seems a little bit silly. But again, just to show you, this is the level of weight loss you can get with this drug that is available. So this is just one of these sorts of phase 3 trials where individuals are randomised at the start. So these will be, we've got 2,500 overweight or obese individuals with comorbidities. And this is the placebo group in blue at the top, so about 2% weight loss there. And then 2 different doses of this drug. So you can see at the higher dose, we're going right down sort of 12 or 10% placebo subtracted weight loss. But this is slightly more effective than the Liraglutide drug. And again, this just shows you that data. So this is what Liraglutide achieves. So basically, we're achieving the same as what the moderate dose, which is actually the recommended dose of this drug, about the same. But if you give people the higher dose, you can get slightly more weight loss with Fentop. And this, I've just included this because it shows you a lot of these studies actually are only conducted over, say, a year, but ultimately it's like any medication, whether it's for blood pressure or for diabetes. Once you're on it for life. It obviously has a cost implication and a quality of life implication. But most studies only go to a year, but this study, they actually followed people for 2 years. And really, the main point is that you can see that if whilst you're on the drug, people tend to say pretty sort of similar. But like I say, there's cost implications for whoever's paying for it, whether it's the NHS or insurance companies, and the side effects also need considering if you're on these drugs. And those side effects with this drug are here. So this is the cost. So actually, it's nowhere near as expensive as Liraglutide. But again, psychiatric effects, insomnia, depression, anxiety, irritability, nervous system issues, so loss of sensation, numbness, headaches, taste, dizziness, gastrointestinal factors, and then these contraindications as well. If you're pregnant, if you've got pre-existing psychiatric issues or hypothyroidism, you can't take these drugs. So these factors always need considering. So that sort of wraps up where we are in terms of obesity medications and what's available at the moment. Like I said in my sort of red diagram, these are probably okay for individuals who are at the lower end of the obesity scale, but increasingly now one of the big issues we have within obesity is that it's not that obesity levels are going up per se, it's that the biggest are getting bigger. So severe obesity is really what is the problem at the moment. And therefore this is why bariatric surgery, which really sort of gained popularity probably sort of 15, 20 years ago and is increasingly being used more and more. This is where weight loss surgery comes in. It's when your body mass index really gets to sort of 40 and above. So all I want to do in this section is just to sort of go through 3 of the most common procedures and show you what they can achieve. So these are the NICE guidelines, so the National Institute of Health and Care Excellence. So this basically details the criteria before you can have bariatric surgery in the UK. So like I said, body mass index over 40 or between 35 and 40 with comorbidities like diabetes or high blood pressure. Must have tried all non-surgical measures before, so you can't just rock up and have this. You know, you have to have consultations with your doctor and try everything before they'll even consider you. And you must confirm that you're going to be willing to be followed up afterwards, because you appreciate people with morbid obesity probably have some psychological issues related to food, why they eat too much and whatnot. Just rerouting their stomach and doing some operations isn't going to change what's going on in the head. So you have to have quite intensive follow-up after the operation. And obviously with anybody who is morbidly obese, we have to check that they're fit to actually have a general anaesthetic as well. So we don't just take these decisions lightly. And ultimately The first one to go through is the gastric band. Many people have probably heard of the gastric band. Literally, as you would imagine, so this is the diagram just of the stomach and the small intestine here. Ultimately, the gastric band is simply a band or an adjustable band that is put around the stomach, which is restrictive, so obviously slows or restricts the amount of food that can come in at any one time in this small pouch here. And it typically works because it reduces hunger. You increase stretch in the top of the stomach, and that sends signals to the brain and switches off hunger effectively. And the positive aspects of this is that you can actually go in and have this done in the day. You can just be seen as a day case to certainly any private medical facility. And compared to the other procedures, it's quite nice because there's no cutting of the intestine or the stomach, and it's reversible. So if for any reason you're not getting on with it, they can just take it out. But we do have issues, so the bands can slip, people then need another operation, and in terms of when we look at the weight loss in a moment, you get less with this kind of less severe procedure than some of the more severe procedures. But there are always complications, so with this one, this was data from a large study in America which looked at this, a meta-analysis. So 2 people per 1,000 operations will die from the gastric band, and about 13% of people have a complication that comes from it. And I think this is similar to sort of gallbladder surgery, certainly the mortality that comes with that. So it is relatively routine now. However, a more severe procedure that leads to greater weight loss is what we call the Roux-en gastric bypass, which looks a bit fancy. I'll try and explain this, but ultimately what they do is they chop off the top part of the stomach there to leave a tennis ball sized piece of stomach, and then they bring up the latter part of the intestine and stick it onto that stomach, and then stitch this immediate part, or this first part of the intestine here, just so these digestive juices can still get into the intestine and mix with the food at a point. But ultimately you have obviously a restricted ability to take in food, because there's less intestine to absorb nutrients as well. You get this malabsorption, so you can't absorb as much as the energy that you've eaten. But one of the main mechanisms how this works is by dumping food at the back end of the intestine, you get a greater hormonal response, particularly those hunger suppressing hormones that I mentioned earlier on. So levels of those hormones after surgery skyrocket and help to switch off hunger. So there's a few mechanisms with this, and the benefits are that you get massive weight loss, which we'll show, but also in terms of people who are diabetic, or in the early stages of diabetes at least, in 80 to 90% of people you can completely reverse type 2 diabetes with this, if you are early stage type 2 diabetes. So the metabolic benefits are very prominent with this type of surgery. But the downside are it's complex. Just looking at it, you can see there's more going on. The complications are obviously greater because of this surgery and rerouting of the intestine and stomach. And this large change in how the GI tract work leads to vitamin and mineral deficiencies, which obviously have to be monitored and corrected. And with this, so the mortality is a little bit higher, the mortality rate, and again the complication rate is higher. So 1 in 5 individuals will typically have to go back because of some complication. And then finally the last one, sleeve gastrectomy, which is a bit of an in-betweener. It's effectively where they just chop off about 2/3 of the stomach and leave you this banana-shaped sort of stomach. So this is mainly a restrictive procedure, but it does also change some of the hormones which contribute to hunger suppression. Weight loss tends to be in between the band and Roux-en, which I'll show you in a minute. But again, it seems to be a relatively simple procedure now, and if you are, you're sort of in for a couple of days and then you're done. So these practices in centres where they're doing a lot of these operations, they are quite routine these days. But again, as you can imagine, this is non-reversible. You can't change your mind if you've got buyer's remorse. And again, vitamin deficiencies and complications are an issue. And if you look at the mortality rates, you see about 4 in 1,000 individuals who have this will die, and the complication rate of 13%. So what's achievable with these procedures? So this is a study from Americans. So these are American individuals who've been in the military, and effectively they retrospectively looked back over time, so 5 years on this graph, of people who'd had the gastric band, sleeve gastrectomy or the Roux-en. And this effectively shows you, when they looked at those records, the changes in weight from baseline. So straight away you can see with the more severe procedure, the gastric bypass, that people's body weight was getting down sort of 30% and was being pretty well maintained over this period of study. If you had the least severe procedure, the gastric band, people were achieving about 10%, and kind of in between with sleeve gastrectomy, about 20%. So this is moving on certainly from the weight loss medications, and you get into this sort of level, this is life-changing, but it's life-changing in the sense that you've lost the weight, but life-changing in the sense that you've also got a completely rerouted gastrointestinal tract. And again, looking at these categories of change, so this is 5% weight loss for each of the 3 procedures, 10%, 20% or 30% over the years of study. So you can see straight away, if you look at Roux-en surgery here, everybody's lost 5%, everybody's lost 10%, 80% roughly have lost 20% body weight, and what's that there, about 40-50% have lost 30%. And again, you can just see the data for yourself, but obviously the least severe procedure, so this is the band, sort of 80% have lost 5%, and so on and so forth. It sort of comes down. So really, and again, so these are the values. So the top orange line is the Fentop, the most effective weight loss drug, and the one below that in the blue is Liraglutide. These are just the comparisons really for the 5% and the 10%. So certainly moving on in terms of what's achievable weight loss. And just showing you this graph, because in this graph they looked particularly at the Roux-en surgery, but over sort of 11 years. So this is quite nice data to look at from a scientific perspective. And ultimately you can see here that patients who've undergone this down to sort of 30%, and actually over quite a long period of time it was maintained. So it does seem to provide a lasting benefit for most people. And then this is the last study I'm going to sort of present today, but if you think back to the very start, you saw this line of what happened in the control group. So this was a study involving 490 centres in Sweden. Individuals who were morbidly obese were not randomised, which is important from a scientific perspective, but ultimately chose to have either usual care or to have Roux-en gastric bypass, gastric band, or a slightly different procedure, which is vertical banded gastroplasty, or which is stomach stapling effectively, which is mainly a restrictive procedure. This data is better than the previous study I showed you because it was a prospective study looking forwards, but the main sort of point to show you is that ultimately if you have the gastric bypass, as you can see here, again down to sort of 30%, and most of it seems to be maintained, although you probably can't see here, if you look at the numbers of people who started in each condition, obviously the numbers go down. So like I said at the start, these are probably the most kind of the best scenarios, because the people who've left are probably those who've put weight back on really. But again, you see with the band in this study was achieving about 15%, which again is above really what any of the weight loss medications can give you. And then very much finally, you could have a module in this sort of topic, but just to show you, there is an argument with weight loss surgery or bariatric surgery that we should actually call it metabolic surgery, because the metabolic benefits in terms of glucose control and these sorts of things are very stark with this operation. And this just shows you data from the same study. So this is the remission from diabetes. So this will be people with early stage diabetes at 2 years and 10 years after surgery. So this is the control group. So if you were in the control group, 20% would have remission of diabetes at 2 years and sort of 10% at 10 years. But if you're in the surgery group, that goes up to 70% at 2 years and is still sort of 2 to 3 times higher at 10 years. Then this last bar here is the incidence over these time periods. So these are the new cases. So new cases of diabetes in the control group, they're at sort of 8% and then nearly 25% at 10 years. But obviously much less lower if you've been, or if you've chose to have the surgery group. So just evidence showing that with weight loss surgery you do also get metabolic benefits which are worthy of note, as well as the actual weight itself. And there's a bit of an argument really to say that criteria for weight loss surgery should come down, and particularly should come down for people who've got diabetes, where we know it can be very effective in the long run. So really just a few take-home messages. So I always think it's important to remember that evolutionary biology is a very strong and potent barrier to meaningful weight loss. We should always bear this in mind, this survival physiology. Weight loss medications support sort of anywhere between 3 and 10%, but you have to consider the expense, which implicates on the availability, and also the side effects and the contraindications, which frequently these stop the people who really need it actually having the medication in the first place. Weight loss surgery, anywhere between sort of 10 to 30%, as the data's just sort of shown you there, but it is extreme, it's life-changing, and it has to be right for the individual. And then finally, the best treatment is prevention, which is easy to say in this environment, well, in this university setting, but actually for most people it's very difficult. But ultimately, like I said at the start, once you become obese, it is very difficult for you to sort of get back and maintain that lower body weight. So the best treatment is prevention. And that's it then. So thank you everybody for listening. Happy to take a few questions.